Hello, everyone. Thank you for attending our webinar today on childbirth safety, birthing injuries, health equity, and birthing justice. Facilitated by Paige Rowe from the Robin Project, Caprice Walsh from the Georgia OB/GYN Society, and Dr. Yasmin Tyler Hill, Chief of Pediatrics from Morehouse School of Medicine. My name is Noor Halou, and I am the Educational Programs Associate with Healthy Mothers, Healthy Babies Coalition of Georgia. I will be the moderator for today. A bit on what this organization is about. The Healthy Mothers, Healthy Babies Coalition of Georgia, or HMHBGA, has been around since 1973. Our mission is to improve maternal and infant health through advocacy, education, and access to vital resources. We accomplish this mission through advocacy and collaboration with Georgia lawmakers and by serving Georgia communities in several different ways. We are excited for our presenters today to lead our session. Please familiarize yourself with the chat box, and we will have around 10 minutes in the end to ask all these any of your questions. Feel free at any point during the talk to send in your questions, and our presenters will be answering them at the end. With that, I turn it over.
Thank you, Noor. So glad to be here. I'm Paige Rowe, founder of the Robin Project, and joining me on camera is Dr. Yasmin Tyler Hill, and I believe off camera is Caprice Welsh. So today we will be, let me see if I can advance my slides. What we'll cover today is we will define birth injury and childbirth safety from both clinical and patient perspectives. I'll be the patient perspective today. And we'll identify who is most at risk for birth injuries, what we know about risk factors and what we don't. We'll describe the long and short-term consequences of birth injury from a clinical, social, economic, and psychological perspective. And then we'll explain why birth injury itself and childbirth safety is a racial justice and health equity issue. We may provide some definitions of what birth safety is and make the case for using safety-focused language in interactions with patients and providers. And as mentioned earlier, we'll finally take your questions on birth safety in our discussion of last 10 minutes. With that, I'm going to toss things over to Caprice Welsh, clinical liaison and certified nurse midwife with the Georgia OB/GYN Society. And Caprice, I'll advance your slides for you. You can just say next slide.
Okay, great. Can you hear me okay?
Absolutely.
Oh, thank you so much, Paige. It's so good to be with you today. And I'm so excited about this topic. I think it's very important, especially in the birth space. We're working a lot on health equity and a lot of the topics and things that we'll be covering today. And I think it's just really important. So I'm really excited about being a part of this webinar today. I wanted to start out talking about traumatic birth. Traumatic birth affects up to 34% of women during childbirth, and it's not something that we typically talk about, but it's something that we're really realizing and beginning to understand as we begin to explore a lot of the maternal morbidity and mortality challenges and looking at the inequity that we are seeing across that across maternal morbidity and mortality. And so what we're learning is that there are lots of factors that are impacting that are beyond healthcare, that are really sort of personal to women, particularly Black women, and things that we have not been paying attention to and not really taking into account, and that we probably really need to start focusing it. Next slide. So I'm going to talk to you a little bit more about traumatic birth. Like, what is birth trauma? Birth trauma is really a distressed experience by a mother during or after childbirth. And trauma really can be something that physically happened, but is really often emotional and psychological. And it's not just about what happened during the labor and the birth, like you went in and you had a C-section and you went in for a vaginal delivery. It can also refer to how you as the mother are left feeling after. Sometimes your expectations of what you wanted to happen didn't go the way it's planned. And in healthcare, we sometimes discount that and it's not a big deal, but sometimes based on how that delivery was done, if it was an emergency C-section, for example, if your baby had to go to the NICU, if you sustained a tear that was really like a bad tear that had to be repaired. That really can be a traumatizing experience. If you think about it, women coming in to have babies are healthy women. Probably many have never been to the hospital, have never been sick, have never been treated for any kind of an illness. And to throw them into, this kind of an environment, and you come in for, they think, a healthy, birth with a healthy person, and everything is going to go well, and things don't go really quite as planned, that can be really traumatizing. So they can experience really an intense fear and helplessness and loss of control and really horror when things really can go astray. And that happens a lot when things begin to happen and they don't really feel like they had the information that they needed going in. And then when they get there, they don't really feel that people are talking to them and telling them enough that they really understand what's happened and what's happening. And it can also be really a trigger for them of an experience that they've had previously as well. Next slide. Trauma, again, the lack of attention to problems patients may experience resulting in injury or death of the mother or child. That's really what a trauma is. Trauma can happen during birth, but trauma can be something that we experience all throughout our lives, right? You could have trauma when you were younger. You could have had trauma with a previous childbirth. You could have trauma, in your, through your losses, through your personal experience, through things that have happened to you. You could have been, someone could have been raped, someone could have been molested, all of those traumas that we experience. And we call them adverse childhood traumas, but these traumas can also happen in adulthood, really traumatic experiences that happen to us and that we carry. Those things don't just get let go. Sometimes they still can manifest themselves. And a mother's well-being in community and hospitals and urban hospitals where there's a failure of diagnosis leading to severe complications and premature birth and injuries can be and have a woman experience a sense of trauma. Again, these experiences going into have a baby or going in for a procedure and then not quite going the way that they thought that it would, and not having the explanation or the time to be able to really unpack that can be really traumatic and problematic, and can also be on top of the personal traumas that you bring into that experience. And sometimes complications and things cannot be avoided, but there are often ways that these things sometimes could have been detected maybe early on and could have been avoided. So knowing that a woman has a trauma that is not really unheard of, to begin to unpack and discuss some of that trauma before they come in for a procedure or come into birth, and beginning to unpack some of the trauma that they will carry through this journey of birth. Next slide. Birth trauma, right, is something real. And in healthcare, as providers, we don't really talk about healthcare birth trauma as much as we probably should. It's really something that I really heard in doing my work around public health and working with doulas. In healthcare, I feel like we talk about anxiety and depression a lot, but we are really not talking about really women's experience around trauma, the trauma from their personal experiences or the trauma that they experience at birth. And birth trauma is, it's real. It is, it's a truth that women experience that we really have to begin to do better in healthcare about acknowledging. And really, it has to be thought of as, even if everything seems completely okay to like a provider or someone else, it may not have been the woman's perception of their experience. And if something happens to her, or if something happens to her baby, it can really leave a lasting impression on that woman, right? They can feel horrified, they can feel fearful and helpless at a procedure that they may have at another time. These things, traumas that they experience, can leave lasting scars that can be triggered again by other experiences. And these traumatic events should not be undercut. They should not be ignored. They really need to be acknowledged. And having a baby, again, after having a traumatic experience, can be a trigger, and have a woman have to work through some of that. It can bring up a lot of fear in them. And we have to begin to talk about those things. In a 2016 study, there was an association between people who've had adverse childhood experiences in their childhood and pregnancy outcomes. The higher their ACEs score we talk about, the higher their chance of having even a decreased birth weight in their babies, and even in delivering at an earlier gestational age. So trauma can have also physiological and impact outcomes on a broader scale as well. Next slide. What is different about birth trauma? We talk about trauma that you experience if you've witnessed a car accident or if you've been in a car accident, or trauma that you could have been a victim of abuse, a trauma from losing a parent. Those traumas, again, are real and experiences that people can carry. But birth trauma, right? People can be impacted by birth trauma. I had a patient impacted by birth trauma, and she had a stillbirth, and she had a lot of fear and anxiety in this birth that I was delivering for her. And I had to really recognize and realize that her anxiety, her being sort of labeled as a difficult patient, her having a lot of issues with the staff, was really around her sort of her struggle to deal with the trauma and fear that she had around that previous birth. So we have to really acknowledge that, right? And women are affected by birth trauma and find that there is nowhere to turn for support. People may not understand, and trauma may not be exhibited by the woman as, oh, I'm scared. It may be that they may be abrasive, they may be angry, they may, seem, combative or confrontational. But sometimes you have to take a step back and really try to get at what could be causing that. And there's not a lot of groups for trauma support. There's not a lot of people don't really talk about it as much as we should. Other friends and family may not talk about the trauma, being traumatized by birth. They may say they had a difficult birth, but they don't really talk about the trauma or the lasting scars of that traumatized birth. And it can be hard to understand, right? If it's something that you've really never really unpacked or really experienced. And, a lot of times women will suffer in silence, right? This can make them suffer alone and feel depressed and lonely, and manifest itself in other ways. And we know that stress on the body is not very good, and really have them feeling really hopeless in that experience. And they may feel really guilty if they're going into deliver a baby and having trouble connecting, or having trouble bonding, or having trouble really feeling happy. There's a lot of feelings of guilt around, the experience as well. Next slide. And there are things that we know that can make birth trauma more likely. There's lots of things we talk about that happen in labor that we just take for granted. And, I've been in labor and delivery for a really long time, and I take things for granted. Like, what's the big deal? We saved your life. You're happy. You're healthy. The baby's healthy. Oh yeah, your baby went to the NICU, but it's doing really well. Or yeah, you had to have a stat C-section, but we saved you and your baby. Or we had to use forceps for the birth, but thank God you didn't have to have a C-section. Shoulder dystocia was a difficult delivery. Someone was pressing on your belly and doing all these things, and no one really talked to you. No one explained things. You had a stillbirth. You had hypertension is very common now. You get magnesium, which does not make moms feel very well. You had to be in the hospital for a longer time. You had to go to the ICU for a little while. It just turned into an experience that you were not prepared for. There's a lot of research that's still left to be done about the long-term impacts of this, but we know that these traumas can be carried for a long time. And symptoms that follow a traumatic event that lasts 1 month after an event, those are the lasting traumas that we're talking about. These things do not go away just because you're, through your postpartum period, or just because you're, had your 6-week checkup and everything seems to check out okay. Next slide. So symptoms of birth trauma can also, lead to a PTSD, and we know PTSD. There is a diagnosis for that, because it really does have symptoms and causes clinically significant or impairment in the individual, their social interactions, their capacity to work, or other areas of functioning. And it's not only physiological and can result in other medical conditions and substance abuse. There are three main symptoms of women who experience trauma. Again, re-experiencing the traumatic event through flashbacks and nightmares and intrusive memories that can make them feel distressed and panicky in situations, so their behavior can be misinterpreted sometimes. Avoiding anything that reminds them of the trauma. This can mean refusing to walk past a hospital or where they gave birth, avoiding meeting other women and new babies. Feeling hypervigilant, that means you're at constant alert, right? Irritable and jumpy. They won't do, they want something, they don't want to do something terrible. They start to worry. They think things are going to be terrible that's done to them, that it's going to impact them and hurt them. Feeling low and unhappy and sort of just being just intimidated and sort of overwhelmed by, the medical jargon that we use sort of very cavalierly, and really impact how they really process, when you're trying to help them process that experience. And they can feel blame and guilt, and which can really impact their ability to bond and connect with their babies. And again, can have other psychological fallout from that, of anxiety and depression, and lead to other other issues. PTSD is real, and birth trauma causes PTSD. I think we cannot just underscore that enough. And it's important to note that the prevalence of PTSD due to birth trauma was 3% in a community sample and 16% in high-risk samples where women experience high-risk pregnancies or high-risk conditions in the hospital. 16% is pretty high. Next slide. And Black women particularly, right, have a long history of experiencing unfair treatment in the healthcare system. We talk about health disparities and racial trauma and racism in the system, systemic, institutional, interpersonal. And we cannot discount the effects that, yes, we know that the high rates of maternal mortality can be attributable to healthcare things, but there are things outside of healthcare that are attributing to that high rate of maternal morbidity and mortality that we're seeing. We're going to have to start to take a step back. And I think that many national organizations around the country, you probably have seen, really begin to put that out there, that racism is the cause that we have to address, that we have to begin to talk about. We cannot change all the effects of racism, but as providers who care for Black women, we have to provide them with the tools they need to thrive and become more resilient, and also identify our biases and our role in continuing that the same burden of race within the system. And again, the impact that it has on women's experiences when they interact with the system. And remember, racism is a major stressor, right? It's a trauma in and of itself. Next slide. Thank you, Paige. And remember, historical trauma is connected to infant mortality. There is justifiable mistrust of the medical system by Black and brown people. They have years and years of unscrupulous practices in science, and then, for experimentation within our communities that have been practiced on Black and brown people since slavery. We'll go to the next slide and look at, there are many examples of this, and the long-term impact on mother and baby cannot be underscored enough. It can cause preterm birth, can cause people can have stillbirth, lack of prenatal care. They can have lots of sequelae based on this historical trauma and being fearful of the medical system. People may say they don't want to come in for their appointment because they have a mistrust for the system, but they can be labeled as, poor care seekers and get labeled as something different. But it could be that the trauma that they've experienced in the system and the fear that they have from this historical perspective is not something you can just sort of blink at. We know that scientific experimentation on Black women during slavery, and people say, oh, slavery was so long ago. That's a long history of being experimented on, and it's not just from slavery. It's been all up through the history, even in the 70s, 80s, 90s, experimentation and utilizing Black bodies for testing, and not even acknowledging their value in that research. Even today, we cannot just discount the impacts of all of the people who have participated in that. We know when we look at Margaret Sanger and the great work she's done with Planned Parenthood, there is a racist component to where they did the contraceptive, began their contraceptive work and their studies in Black communities, really to sterilize. And, with Henrietta Lacks using her cells without her knowing, we look at the trauma around Black women having to breastfeed, white women's babies and not able to even nurse their own or have enough for their babies, and then have their babies stripped and taken away from them. These historical traumas are persistent in the Black culture and community, and have to be acknowledged. And they may seem long time ago, but the Tuskegee experiment is one that people know very well. But these have left Black people feeling that they cannot trust that system. So the way that they seek care and engage with care is impacted by those experiences that they have experiences. And they were not hundreds and hundreds of years ago. They were not that long ago. And so that we have to acknowledge those experiences and the trauma that those experiences have caused. Next slide. So really, we have to begin to provide care that is trauma informed, right? That focuses on women's ability to adapt and be more resilient, and right, not just examining the symptoms of the trauma, right? We want her to have resiliency over the pathology. We want to avoid the generalization about the trauma and what it caused and what it does, and acknowledge the history and culture and value of all of our clients and what they may have experienced. And when we consider interventions, we have to really think beyond the healthcare perspective and really the broader economic and geographical and social determinants of health that may impact one's ability to really interact and engage in care. There are trauma-informed screening tools that are excellent that I think providers need to incorporate into their care. There's an ACEs screening tool and linked to leading causes of early death in adults. High ACEs scores are these tools, again, get at the adverse childhood experiences that carry into adulthood. There's the Urban ACEs questionnaire, the life event checklist. Trauma-informed care is one where we're intentional about recognizing the trauma, acknowledging the trauma, and again, really helping women to be more resilient. Next slide. So the key principles of trauma-informed approach when we're thinking about how we're going to deliver a trauma-informed approach to care. These principles are really important and highlight the tools necessary to ensure trauma-informed decision-making. Approach needs to be safe and promote and sustain safety. People need to feel safe first. People who feel safe, who feel unsafe, do unsafe things. So providing a safety that women can feel is really important. Trust, listening and validating. People can live up to the trust that you give them. Our goal as providers is to connect with them and hear them when they say that something doesn't feel right or is not right. Peer support and education and training for providers so that we can understand the trauma and its impact. Collaboration and partnership, right? We want our care to be patient-centered and collaborate without patients on the care. Empowering, support women's choices and autonomy in the process. Remember, there are multiple viewpoints that you can consider, and be sure that they are participating in the care and decision-making, and ensure that we practice with cultural humility, right? Check our biases and show respect. Whereas we're not only taking in our interpersonal stance that is focused rather on ourselves, but really consider the lived experiences of women, looking at the whole person. We have to begin to show more empathy. And remember, we are all in this together.
Thank you so much, Caprice. I was taking notes. I really appreciate what you brought to the table, and that was an excellent presentation. And now I'm very pleased to present Dr. Yasmin Tyler-Hill. Give me a second, Dr. Tyler-Hill, and let me pull up your presentation right here. And you can take it away.
I muted myself because the fire trucks came and it would have, we would not have been able to hear Caprice's talk. Thank you so much for inviting me to this talk. This is very important work. As you know, I'm at Morehouse School of Medicine, where one of the big areas we focus on is health equity. Morehouse School of Medicine is one of 4 historically Black colleges and universities in the United States. And I think the important takeaway, just a very simple takeaway, is that racism and its impact on healthcare is a very important predictor of health outcomes. And so depending on some of the things that you look at, when Paige asked me to talk about birth injuries, as a general pediatrician, obviously I had seen many birth injuries, from broken clavicles to brachial plexus trauma to petechiae to all sorts of things. I don't consider myself an expert, but what is really important is that what I'm interested in and what I think we can share today is sharing what are the disparities and how do we know they occur. So I did a literature search, and there's not a whole lot of literature out there. Paige, can you go to the next slide, please? I'm sorry. While we're talking, I just have to say I have no relevant disclosures of conflicts of interest. Next slide, please. When I went to the literature to look at disparities in the area of birth injuries, I really found very little information. And that doesn't mean they don't occur. That just means people haven't looked at it yet. And I think as we are coming into this time of understanding, as Caprice said, those other issues, not the genetics, not necessarily the quality of the physician, but the interactions and the other things that impact health outcomes, we have focused more on those differences based on race. And so that's what I will focus on today. So as we're talking about birth injuries, I'll have a very quick overview of what birth injuries are. You could go back one more page just to make sure that, because I can't remember, the evidence of racial disparities, the incidence and outcomes, and then sort of what are our next steps. So if you could go ahead to the next slide, thank you. So the good news from this very busy slide is that in the last 40 years, the incidence of birth injuries have gone down. So what has happened is that we figured out the science behind it. We've improved care. However, what we know is that there are disparities that still exist. And where I was able to find literature on those disparities were in brachial plexus, that there's a moderate increase in African American, Hispanic, and females, female infants with experiences this more. And in premature infants. And so taking that information, I wanted to bring that to how we would look at the concept of birth injuries as it related to health disparities. Next slide, please. So if you look at what are some of the birth injuries that occur, so from an epidemiologic standpoint, everything from dermatologic, skin, bruises, lacerations. We had a friend who had a baby and the baby's ear was cut during a C-section, an example of a birth injury. They're what we call extracranial, outside the head. And I know many of you have had a baby, delivered a baby, or taken care of a baby, they would have a caput or a cephalohematoma. And that's part of birth trauma, and parents see the baby and they say, what's going on with my child? You might see retinal hemorrhages in babies as a part of birth trauma. And intracranial, much more serious subdural hemorrhage can occur. Neurologic injuries, as we've talked about, brachial plexus, and we'll focus more on those because those are probably the more common of the birth injuries that we see that have resultant long-term impacts on babies. Then orthopedic injuries, clavicle and long bone fractures, and with the long bone fractures being seen more in premature babies, and intra-abdominal injuries that can be quite severe. and actually even life-threatening. So these occur, and the real issue is, do they occur in the framework of health disparities? Next slide, please. And so I would say yes. And while the evidence for that is, as some may say, is not enough, I think that one has to assume that what we know about birth outcomes with mothers, that we can take some of this to look at birth outcomes in infants. And so, and I do believe that there's an opportunity for us to look more at that, but more for the opportunity to look at what happens to infants who have resulting outcomes or resulting damage from these birth injuries. And that's where I'm really interested. Do babies get the same kind of care? Are they going to be at school age able to function at the same, depending on their race? And so that would be the focus. So we know, and I think Caprice talked about a lot of these, but just to point out, I was very pleased to help co-do a conference on maternal and infant morbidity and mortality for the Henrietta Lacks conference that's held every year at Morehouse School of Medicine. And I learned quite a bit. And what I learned is that African-American women are 3 times more likely to have maternal deaths in the United States, but all women in the United States are more at risk for death. Here we are, the richest country in the world. We spend more on healthcare than anybody else, and yet we have this still going on. There are 700 pregnancy-related deaths that occur every year. And so that number, to me, as a mother of a childbearing daughter, hit me very, very strongly, and I'm sure would the same to you. Non-Hispanic Black women have the leading cause of death or cardiovascular condition. Many of these preventable, and many of these based on what I think Caprice alluded to around disparities that are related to racism, and where the Society of OBGYN is really working on. Black women are more likely to have severe maternal mortality, morbidity. And what we know is some of that morbidity related to obesity and diabetes directly relates to infants having an increased risk of birth injuries in terms of their having larger bodies and having more common social dystocia, difficult births in there. And that one study found that Black women were had a 2.1 times greater incidence of this. Next slide, please. And as we go on, I know this is very small, but what it basically will tell you is that if we look at bad outcomes for infants, for birth outcomes, we know that in the areas that have been studied, African-American infants have a worse outcome. The infant mortality rate is 2 times higher. Even though we make only up 15% of the births, we have 29% of the deaths in terms of African-American women, so African-American infants. So looking at that, preterm births, low birth weight, are much more prevalent, and these are things that have been studied. So we know this science. They're and much more likely to be born, Black infants be born preterm than white infants. And while genetics may, and education level, may play a role historically, that's what we've thought, the more and more we begin to look at some of these outcomes, we're seeing that there is not this play of genetics, that African-American women who are in higher socioeconomic brackets have the same bad outcomes that other Black women have. So they're more likely to have a worse outcome than a white woman who is of a lower socioeconomic group. So even though we put those two together and say socioeconomic poor outcome, that does not hold true for African-American or Black women. And so again, we look at this being related to race. And then when we look at the data around where women live and some of the stresses, and I'll talk a little bit about toxic stress as it relates to what Caprice talked about were ACEs, adverse childhood events. And what we know is that those events that occur very early in childhood may have a lifelong course, that what happens to you in birth will affect how your life trajectory goes up into adulthood and in terms of birth. So some of the science is that women who are babies who are born small birth weight are more likely to have hypertension. We've said that the most likely cause of death in a woman from a pregnancy complication is what? Cardiovascular, what? Related to hypertension. So this all is a circle and a cycle that goes in with a real focus based on race. And I want to just say, what is race? Race is a social construct. It really has very little to do with genetic outcomes. If you look at, there's an excellent issue of National Geographic that looked at following genetic deposits from people from Africa, which were the first man, and how they went up into the northern parts of the world. And really, there is very little difference. There's more difference between folks born on the West Coast and the East Coast of Africa than there are between whites and blacks who came from those groups of people. So just a sort of interesting thing when we say it must be genetic. It must be based on what the behavior, and we can talk a little bit about that if we have time. Next slide, please. And so this just goes on to give some of the statistics of how Black children are discriminated against or have this disadvantage, and it's based on race. And we've had 450 years of racism in this country. Again, I go back to what Caprice said, because it's basically the same thing, the 1619 projects. And so for 450 years, no, this has not even changed up until this day. This morning, I was in grand rounds with our surgical residents, and what they were giving were sort of, we were talking about stereotypes, and then they talked a lot about how they are meeting those in the hospital now, where people are saying, well, when is my real doctor going to come in? So we're still in this day and time, as of yesterday, dealing with some of the structural issues around racism that make it, that impact the health of African Americans. Next slide, please. So I want to go and tell a little bit about the levels of racism and the construct of how this impacts health. And I know many of you may have heard of Camara Jones. Can I have the next slide, please? Camara Jones, who is a physician and a social scientist and a public health person, but she first coined this, and she gave a tale of and how we look at the levels of racism and how it is racism that impacts and makes up for the difference in health outcomes. And as we know, there are multiple differences in health outcomes. It is all through the literature that one can see, from getting pain medications. I had a conversation with one of my colleagues, outcomes in transplants, outcomes in pregnancies that we've talked about, in birth. Many of these discrepancies or disparities that then lead to poor health outcomes long term. And I'm putting that same model with birth injuries. So children who have long-term sequelae of birth injuries, are their outcomes the same as are we across the board, are children having the same outcomes, or is there a disparity? Something that may be an opportunity to look at. So the gardener's tale is that a gardener had some seeds of red plants and pink plants, and they got a new house, and they had one flower pot that was empty and one that had been there for a while. And so the gardener went out and bought some new beautiful soil and put it in the empty flower pot. And then she decided, she said, I really like the red plants, so I'm going to put those into this new soil, and I'm going to put the pink plants into the soil that was here. And and she watered them equally, and as they grew up, what she noticed was that the red plants were really growing, and yet the pink plants weren't really growing very well at all. And she sort of thought to herself, well, I told myself, these pink plants, I now know I really like the red ones because they're stronger plants. And even though the red plants, they grew really tall, and even the weaker seeds within the red plants got up to a certain height. But in the pink plants, even the stronger seeds couldn't quite make it out of the middling group, and the ones that were poor just sort of dropped off. And so over years, these plants grew, and they would drop their seeds, and the same thing continued to happen. There would be these really nice red plants who grew, and even the weakest of the red plants grew to a certain level, and the strongest of the pink plants really could not get out. And so the gardener would come out and she'd look and she'd just be just enamored with her red plants. And then she said, well, she would see that sometimes the seeds from the pink plants would end up in the red pot. And while they would come up a little bit to see the flowers, she saw they didn't grow and she'd pull them out. They never really actually made it in the pink plant. So none of the red seeds ever, even though they were dropped in there, never could grow in that pot with the pink plant. And then when the bee came by to pollinate the plants, the pink plant said, no, I don't want pink plant pollination. I want red plant pollination because that's the best plant pollination that's out there. And so again, this plant was, the plants were saying, no, I don't want that. You know, I'm not as strong. And so this went on for years. And luckily, as that went on, the gardener was more assured that red plants were the best plants, and she kept telling them that, and the pink plants were just these ugly plants that were just not even worth growing. So that's the tale of the gardener's plants. It gives us a really nice allegory for the types of, or the levels of racism that impact health outcomes. So institutionalized racism, as you might imagine, is that racism that starts from the beginning. So the soils, how we separate individuals, and we already have a bias that one is better than the other. So that historical insult, that structural barrier, the separate plants. So we had integrated communities, we had redlining in neighborhoods, and so people could not move into the same area. We had separate and unequal schools up until 1954. I actually started out in segregated schools. So again, this went on. You know, there's an action in the face of this need. It's not there. And then this becomes, after a while, a societal norm. We begin to tell ourselves that the pink flowers are inferior, and indeed the red flowers, no matter what, can grow up, because we don't see them going poorly because they can't even make it in that poor soil. And then we say, well, it must be related to their genetics. One is better than the other. And then the red plants begin to get more and more privileged because they got the good soil because of the bias of this gardener from the beginning. And then there becomes this personally mediated racism that the gardener, as is this sort of stereotype is fulfilled with her. It becomes intentional and unintentional. So she has this bias that the reds are better. And so does she give that red more water? Does she put it more in the sun? And so that's her unintentional bias. And her intentional bias would be saying, I am going to plant my third pot with just red flowers because I know those pink flowers are no good. And it becomes an act of commission and omission. And then we maintain those structural barriers. She's not going to try to take those pink plants out and put them, she's been pulling them up out of her red plants because in her mind, they are inferior. And then these kinds of things are condoned by societal norms. Everybody who comes by and says, well, you know, the pink flowers were just the poor, bad flowers, and the red flowers are the ones that are really the best and the strongest. So when I plant my garden, I'm going to plant red flowers because they are the strongest one. And then there's internalized racism, where the pink flowers tell the bee to go away because I don't want what is mine. What mine seems less. So my young doctors today were talking about how they were being questioned about being the doctor. Even if they were the attending, the more senior doctor, and there was a medical student who was a white male, it was assumed that that medical student was the doctor and the chief doctor. And so that plays into your whole psyche and your trauma that you deal with. And then it becomes, again, to reflect societal values and societal norms. And this erodes at the individual sense of our value and undermines collective action, these microaggressions. And how does that then play on the health of the individual? And we are beginning to learn more and more about that. Next slide, please. I just want to bring to you this AAP policy on statement and race. Again, the impact of racism. And it's not race. Remember, it is the ism of the race, the one that we consider that is not based on any genetic foundation. It's not based on any kind of physical difference. Even the differences in behavior are based on the stress, and we can talk about ACEs and toxic stress, and how we're actually beginning to see how toxic stress may be getting into our DNA, which is a whole nother talk that one can do. But the stress generated by experiences of racism may start through maternal exposures, okay, while in utero and continue after birth with the potential to create toxic stress. And so how might this impact, and we can talk about this in the question and answer, how might this impact a baby with birth trauma in that baby, and how would that come out, and how might that look? We have to answer those questions. I don't think they're out there being answered, but they should be asked. Next slide, please. And then I've talked a little bit about structural racism. You will hear the terms explicit bias, which is that we usually call racist or prejudice. Oh, there were good people on both sides. It is not Black Lives Matter. It is all lives matter. Explicit sort of, there was widespread cheating in Detroit in the elections. Why widespread cheating in Detroit and not in the next Macomb County, which is next door? And that content of toxic stress. And this will be a field of study, I believe, in the future, as we actually look at how our brain and endocrine system go to impact what happens to us, and then what happens to our babies that are born in that situation. Next slide, please. Again, I want to share with you the basic science of pediatrics. It is all coming in together, and this is where I think the real exciting part of science is. So it's the ecology, the society, and the physical environment. If you tend to live in an environment with more toxins, if you tend to live in an environment that is a food desert, if you tend, and without walkable sidewalks, you're more likely to be obese, and you're more likely to then have related type 2 diabetes, and to bear a child who is large for gestational age and more at risk for having a birth injury. What are the biology of this? So a mother who then is born prematurely is going to have a low birth weight, born at a low birth weight, is more likely then to actually develop obesity later on related to hormonal changes. And we can actually look at that down to the DNA section. And then the overall environment of which there's health and development. What is your access to care? What are your opportunities to care? What are the stress factors that are in your family that allow you then to make decisions to move forward? I often hear people say they're non-compliant. Well, you're non-compliant if you don't have a car and your hospital is not on a, or your doctor's office is not on a public transportation roadway. Next slide, please. And so we can actually skip this, but just to say that if you, I said skip it, but I didn't really mean it. African-American babies really have the highest rate of late or no prenatal care. Other than, I think these are not Native American, but Pacific Islanders are higher than African Americans, but we are second in the United States if we look at these sort of outcomes. Next slide, please. And then this was, I think, one of the latest studies that I just want to share with you. It was a study of looking at 1.8 million birth records in the state of Florida. And what they basically, the basic outcomes is that babies who were born and ended up having in a hospital that had a Black physician take care of them were less likely to die, this is death, than white babies. And this becomes very important with my work at Morehouse School of Medicine, that again shows you that there's some other factor. And what is that? Are Black doctors better trained? Are Black doctors smarter? No. What is it that we're doing that is different? And is that related to this racism that we see. So, and something, this just came out in September, and so something that I think we have to begin to look at. Next slide, please. And so as I end with hopefully some time for, well, not much time for you to give your talk, but I just want us to think about that all lives matter, all babies matter, Black babies matter. Thank you.
Thank you very much, Dr. Tyler Hill. And I'm going to speed through so we can reserve about 5 minutes for questions. And then I'm sure that any of us would be very happy to answer additional questions as we need. So just very briefly, I'm founder of the Robin Project. My daughter experienced a significant birth injury when she was delivered, and I as well had significant postpartum and delivery severe complications. So I'm speaking from that perspective, but I've also spoken with many, many, many birthing parents and other parents whose children and they themselves experienced traumatic physical and emotional deliveries. And so my representation here today is from that research with them. I have no financial disclosures, so we'll just start there. Just so very briefly, from a patient perspective, birth injury can be physical, emotional, or spiritual. And you've heard that from the other two providers from the emotional and physical side, but also to add the cultural perspective of delivery differs across depending on who you are, expectations for that, what kind of experience becoming a parent is or becoming a mother is, and what those expectations are if that goes wrong. And there can be a spiritual injury that I think when we talk about distrust and mistrust of providers, perhaps there is room there as well for spiritual providers to engage in that. I want to reiterate something that was really important that Caprice said earlier. The perception of the person experiencing the trauma, be it physical or emotional, is what defines whether the experience is traumatic, rather than the perception of other people involved in that experience. So the most important thing I want you to take from this presentation is that the path to actually diagnosing whether there is a physical or emotional injury is very complicated. And this is, I think, one of the key aspects of why this is a racial justice and a health equity issue. So there are many different points at which a patient may identify that the symptom or the thing that's wrong with their baby is not just something that happens during childbirth and will resolve itself eventually. And so you may find out from your OBGYN that you had a tear or a broken tailbone, or that the nurse who treated the baby as soon as it was delivered may identify a floppy arm. But over time, whether these symptoms improve or worsen is what will often determine for the patient whether they perceive themselves to have had an injury as well. And whether that's diagnosed formally and treated is complicated by insurance coverage, financial status, employment status, whether they can get off from work to see a specialist or see a provider about their condition, their own awareness of whether that's a normal symptom or not from hearing from their patient friends and family members. What we heard from Caprice and Dr. Tyler Hill, social lack of trust, depending on who you are in your providers and whether they will tell you what's really going on. And also that many of these injuries, particularly brachial plexus injuries, are not formally diagnosed until 6 to 8 weeks after the infant has abnormal movement in one or both arms, right? I'm not a provider, so I might have said that wrong. So there's a period of time in which it takes to know whether this is a true injury because it's lasting in some way and requires treatment or evaluation, or whether this is a function of childbirth and delivery. And there is also stigma around this still to this day, the gynecological aspect of this, that many parents, women who identify as women in particular, feel difficulty talking about these things with other people. Again, with an infant, it's very much, that similar situation. There could be multiple providers who could determine or identify whether an injury has occurred. And we see this time and again when we look at socioeconomic status and attainment, when we look at, irrespective of socioeconomic status. Dr. Tyler Hill referenced Black women, irrespective of socioeconomic status or educational attainment, may still be treated the same or have the same outcome. So again, consider that when you're trying to achieve a diagnosis after a difficult delivery, how difficult that might be. A little bit of information on Georgia, since this is the Healthy Mothers Babies Coalition of Georgia. There have been some very preliminary information about this done with the Georgia Department of Public Health at the Robin Project's request in 2017. A similar study was done in California, specifically on brachial plexus injury. Ultimately, they still found, both studies found that the rate was very low. The challenge with both of these studies is that they were using electronic birth records or hospitalized inpatient data. As I said earlier, the idea that someone may still have long-lasting effects of a birth injury but not be hospitalized leaves out a large group of people who may not receive follow-up care or a diagnosis subsequent to when they were in the hospital. They may not receive that diagnosis in the hospital. So we really don't know how many patients and how many babies actually have some of these injuries outside of the research Dr. Tyler Hill referenced of looking at these meta-analysis. We do know that in Georgia, Black mothers, as mentioned earlier, are at highest risk for death in childbirth. And that does beg the question, well, what about Black babies then? Are some of the similar social and institutional reasons why Black women are dying at higher rates also contributing to sort of unknown levels of infant injury and morbidity? And I think that that's something that's really important for any researchers on this call to explore. One thing that helps us believe that that may be true is a British study, which found that there were similar racial and social economic risk factors for Black patients. The risk for brachial plexus injury in Black patients in England was 6 times higher than for white patients and 2.7 times higher for Asian patients compared to white patients. And this was especially among lower socioeconomic groups. So this tells you, as the California study also found, that insurance status and insurance coverage is not necessarily an indicator of whether this will happen. It leads you to think there must be something else. And of course, as you've heard from the two speakers before, that other thing probably has a lot to do with institutional racism. Very quickly, what happens to a child with severe birth palsy alone? This is my baby. She's a bit older than this now, but approximately $150,000 in medical costs can be incurred over the first few years of life, $700,000 in medical expenses for the rest of the life if they have access to that and are able to pay for that, multiple surgeries and therapies. This is not something that goes away. What happens to a patient's family with birth injury? Well, this is where there isn't a lot of research, but we do know that simply arranging for care, obtaining care for a child, can be an ordeal that affects many aspects of family life. And the strongest impact of this injury is the emotional reactions and social isolation of mothers or birthing parents. And I've heard personally many patient family stories of people having to quit their jobs in order to provide adequate care for their children, in order to get their children to their multiple appointments, or losing insurance status because this is considered a pre-existing condition, even though it happened during delivery. So we know where there's smoke, there's fire in Georgia. Mortality may be an indicator of severe morbidity in infants. We simply don't know. And at the end of the day, we really do have to study this from a birth injury and racial justice and health equity perspective. And I want to call your attention to this quote from Tiara S., a physically disabled woman of color, who said, "The biggest thing for her was to be able to work and wed. She is a woman. That means she makes 78 cents to the dollar compared to men. She's a person of color, so she's less likely to get even that much. She's disabled, so she has to deal with prejudices all around. The most pressing issue for her is trying to prove that she's just as good as her white, able-bodied male counterparts, all the while trying to keep the lights on." And that may be the future of many of these babies that we simply haven't counted. We don't know who they are. We don't know what challenges they face. We don't know how to best support them. And most importantly, we don't know exactly what we can do to help prevent them from being injured in the first place. So just as a reminder really quickly, physical safety, emotional safety, and spiritual safety are I think the language that we should talk to in the future. How do we talk about prevention of risks? How do we talk about making sure that emotional safety is accounted for? And how do we make sure traditions and beliefs are respected and attended to? Providers can do this very clearly by considering a birth parent's race and the baby itself potentially as a risk factor for complications if that patient is Black, Native American, or Latinx. Take a moment to pause when a patient complains of a symptom or is concerned concerned about their baby. Ask about their biggest fears, both physical and emotional, and consider how other support systems, when we refer to that spiritual safety, can be encouraged to be leveraged to assist patients in dealing with the trauma, dealing with the historical trauma, and some of the other things that we've talked about to help assure improved outcomes for these populations. And last but not least, these are a few of the resources that we can recommend to you, and I'll pause there because we are actually at time. So I don't know if we're able to do any questions or not.
Hey, no, we have a few minutes that we can allot for questions and answers. So if attendees want to go ahead and send those questions in, we can answer a few. I will also be attaching this presentation, so the presentation slides and the recording, to a follow-up email I will send a few days after today. So no worries.
Phew.
And that wasn't.
I was talking real fast.
Wow.
No worries. This was an excellent presentation, and I appreciate you all so much for talking about this. One question that we have is regarding follow-up. Has there been a correlation between birth trauma and decreased postpartum visits?
I'm not aware of that.
No, not aware of that.
No, me either.
And I'm trying to think. I don't even see that in. No, there's not been. I'm trying to think of other.
Now, and I would just say that if she's saying decreased postpartum visits, sometimes people will be afraid, sort of, to come in and face, the provider. If they had a bad experience with that provider,
Yes.
They could delay or not come back for follow-up. We know that there is a lack of follow-up in the postpartum period. And could that be some of the cause? We haven't explored that, right? We say, oh, because they can't get there, they have childcare issues, or women just let it fall through the cracks, or maybe I'm done with the whole situation because it was so traumatizing for me that I don't want to come back.
And then also remember, if there's a birth injury, this mother has a baby who may need to have increased surveillance.
Yep.
And they are looking at this baby, and a mother will sacrifice herself for her child. So that's something to always think about with moms.
Absolutely true. We hear that from the patient perspective, that you see kind of, depending on the patient, you might see that they want to go into that 6-week checkup and talk to the doctor and give them a piece of their mind about what they think happened. You also see the other side, which is what Caprice referred to, that as the overly confrontational maybe side of birth trauma. And then you might see, on the other hand, you just go into a different doctor. You don't want to go back there. You don't want to go to that hospital again. You don't want to see that provider ever again. And so there may be that follow-up occurs in a different way, or someone says, you know what, I'm done. My baby has an issue. I'm going to focus on that, and whatever I've got going on can wait. And we do see that.
Gotcha, great answers. The next question that we have is, has the state of Georgia engaged in any research on this issue?
Aside from the 2017 study that I shared with you, and I'm happy to provide more information on that, no. However, Children's Healthcare of Atlanta is funding a study through their physician philanthropy group, the 1998 Society, to study for the first time brachial plexus injury prevalence in Georgia for the past 10 years. And I'm participating in that study. I received no money for it, and we're very excited about that. That will be a landmark study because it's actually going to evaluate ICD-9 and ICD-10 insurance codes through the whole state with electronic birth records, Medicaid and Medicare, I guess, as well as we're trying to get a couple of data use agreements with a couple of other hospitals. So it will apply to patients who haven't been hospitalized for brachial plexus, which is really important because most babies actually aren't hospitalized for this unless they need a surgery, and that's a very small number. So in order to get a bigger picture, we're going to look at babies who maybe have just had therapy or have been diagnosed by their doctor but not actually had to do much else in that time period. So that we're very, very excited and grateful to Children's Healthcare of Atlanta for investing, and the physicians investing in that.
Awesome. We have another great question. This question is, how can healthcare facilities approach an action plan for reducing disparities in care?
Well, I think it starts with the first recognition of some of the structural issues that are embedded in our healthcare system. And so let's just start with the number of physicians of color who identify with patients are the same. And so there is a disparity there is where it starts. And I think acknowledging race, not so much as a genetic concept, but as an ism concept, racism. And for instance, we have stopped how is it important that we know that somebody is African American? How is that going to make us want to look at that patient differently? And so I think also dealing with the issues of implicit and explicit bias. So again, a lot of work is being done around the physician-patient relationship or the healthcare provider physician relationship, and what are the situations where that becomes a barrier to healthcare and health outcomes for patients. For instance, I quoted some studies about pain medications, less likely to get certain cardiac procedures done if you're African American. We know that African American males are more likely to get tested for prostate cancer if they're seen by an African American physician. We need to really unwind some of that and really begin to include that into our medical school curriculum. So it comes from our workforce in creating the right doctors with the right skill set to be able to do that. It also becomes looking at what we have in terms of structural racism barriers that we put up in our healthcare systems.
Caprice, did you have anything to add? Because if
No,
you
that
did,
was I know that was great. That's exactly the line I was thinking. You know, we have physicians in the workforce already. We have to have some acknowledgement, but I think really beginning to embed it into educational programs in midwifery and nursing and in medicine is going to be, you know, train up the army you need, right?
Right.
To see. So I agree.
just from the patient perspective, I think sometimes not to, I agree with the provider perspective. From the patient perspective, ask the patients.
Right.
It's very important in birthing classes, maybe to follow up with Black parents of color, Black parents or Latinx parents, and specifically ask them, how was your delivery experience? What would you have liked to have seen differently? There are these surveys that go out, at least the hospital where I delivered, how was your delivery, over the phone? Like, I'm not going to answer that. It's awkward for me, but can you get some parents together, and ask them what could they do differently? Because I think sometimes we have this also bias of that the provider knows what services the patients need. And it's really important, especially as we try to be anti-racist, to follow the communities themselves and what they ask you for. It might not be something that's traditionally what you think of in a healthcare system's responsibility, but the transportation issue one is probably really big, right? So could you really improve outcomes by simply offering bus vouchers or having appointments outside of normal business hours? So just to add to that.
We have a society that's pull yourself up by your bootstraps. But if you've been tethered down, you couldn't pull yourself up even if you wanted to. And I think that's the concept of structural or institutionalized racism that we have to understand. We've got to cut those chains away that have not been cut away. And there are multiple out there.
And the policies and laws and things that are in place do tether you. And we don't talk about those. Like, what are those? Like, people think that it's so, it's like out of the sphere of even thinking about. No, there's policies probably in your institutions. If you just really go through and check, think about it. Like, who gets screened for drug testing?
Right.
Why are some rules in place? Like, what was the history behind that? Who made those rules? Who was a part of that decision?
Right.
Become also what tethers people down, right? Yep. So we have to address those.
I think we could go on and on and on and give 3 separate talks and really do this. It's obviously a passion, and it really is where healthcare, because we want outcomes. We just don't want care. We want outcomes. The United States has the worst outcome of the 12 leading industrialized countries, and yet we spend more on healthcare than any of them.
Yeah, well, thank you three for presenting with us and sharing all this critical information. This was an incredible presentation, and I really appreciate all three of you, and I appreciate everyone who's decided to listen in today and share this space with us. That concludes the end of our Q&A session. However, in a follow-up email that I will be sending out, there will be a survey that if you need a CE credit or a certificate of attendance, you can request that. And if Paige and Dr. Tyler Hill and Caprice are comfortable with, I would be more than happy to include their contact information.
Great.
Absolutely.
Well, I wish everyone a wonderful day and thank you, everyone.
Thank
Thank
you.
you.